wanted to thank the organizers, and what a fabulous facility it is. I've been to many of the facilities here, health facilities in Salt Lake over the years, and this is an incredible place to walk down the hallway and see the people about whom all of this work is about. And so thank you to Genetic Alliance, and Sharon has really played a key role in driving policy to get to outcomes, which is the title of this session. I'm going to introduce the speakers and then have them go through, and we'll take the questions afterwards. I don't have any grand pontifications to make other than seize the opportunity you have here to leverage the voices you have. While it's clear, just in the last several years, the notion of the mobility of information, the elements of consumer engagement, and the freedom to express information about your own health in many ways and use it in many ways is rapidly changing, as is the elements of how genomic information is being applied in healthcare, that this window of opportunity of really trying to get it right isn't going to last forever. The question I was going to ask earlier is I still don't know why one mode of delivery of lab information is the norm. Many parts of our economy thrive on diversity of the ways in which they communicate, and I would charge everyone here to really think hard again about there are great opportunities for innovation all over the place in healthcare right now, and don't be held back by the premise that the way we're doing it now is the right way to do it. In 1971 was a pivotal year for me. I don't often share personal stories, but it was an important one for me that this notion of being involved around this nascent effort around family history and steeped in the community of this part of the country for many generations now has led a lot to scientific discovery, but also a sense of community overall. I was a sophomore in high school, and I was asked in this very small town in Michigan to work part-time for a family practice in this small town where I grew up, which was a very agricultural, rural area. And the doctor's electronic health records at the time were 5x7 cards held by rubber bands. And on the back of each of those cards was a family pedigree. And it was, I had studied genetics in high school with a great science teacher, and I was curious about why she did this. And she was a big fan of ancestry and many generations from European cultures that emanated to this country. But she used it principally when I talked to her about it well after she retired, and she passed away about 10 years ago. And I asked her, well, why did you do all of that? And other than the curiosities about it, because the associations of cancer and a lot of other diseases wasn't known at the time. But she used it as a business model to be able to predict how many babies are going to come next year, what the practice was going to look like a generation from then. And she used it as a business planning model and could also show and teach others about that. And that stuck in the back of my head for many years. I think there has been a great deal of progress been made here in understanding the importance of getting this right, of being able to annotate disease and risk. So I'm pleased to be here. Many of the folks on this panel are my friends. They've taught me a lot over the years, and I want to be your advocate. And so we're going to go through a series of the things that they've been doing to push the envelope a little bit, and I admire their work. In many ways, I'm jealous of the successes that they've had in academia that avoided my career. So, Marc Williams is the director of Genomic Medical Institute at the Geisinger Health Center, very prolific in his comments and thoughts in this space. Ken Kawamoto is the director of Knowledge Management and Mobilization, assistant professor here at the Department of Biomedical Informatics at the U. Mark Hoffman is the vice president at Cerner in Kansas City. And Philip Strong is a hospitalist with the Palo Alto Medical Foundation, a place that's doing a tremendous amount around patient care and coordination. So I'm just going to ask you to go through, thank you all for your work on this topic, and I'm just going to ask you to go through a series of your presentations, and we'll do questions at the end. Thank you.
While my talk's getting set up, Greg is much too modest to mention this, but the American Health Information Community that you were hearing about a lot today, he was managing that program for all intents and purposes, particularly the personalized healthcare aspects of it, and did a phenomenal job of bringing that through. So In fact, if you go back and look at some of the papers relating to family history standards and that sort of thing, you will see his name there. So he's had a major contribution to what we're talking about today as well, despite his modesty, and it's something that I am genomically null for. So I wanted to run through a clinical scenario and a gap analysis, and many of you have seen this before. So we're going to present the clinical scenario, and then I'm going to use this scenario to address the three organizing questions that we were asked to do. So this is a screenshot from the family health tool that we developed here at Intermountain when I was here, and it's still being worked on today, and Grant is kind enough to let me use him as the participant here. And so we're looking here in the patient portal, and this tool is live in the patient portal. Patients can go in and enter family history data. And so if Grant has filled out his family history, and up here he can print it out, but he could also use a blue button function to basically contribute this to the electronic health record. And he does so. And now we're in the electronic health record view, and this is my message log as his clinician, and I see I have a message from Grant Wood, and it's a family health history message. Patient has logged into the My Health patient portal, completed a family health history that shows an increased risk for familial disease. So some algorithm has already run. It's already said, hey, you need to pay attention to this. The family history and risk assessment are available for your review. And I can choose to view it either as a table or as a pedigree. We find that most geneticists prefer to view things in a tabular view, and so this would be the table. And what we see here is that there are some individuals with heart disease that have occurred at a younger age. And I can upload this to the web form, so with that one button it would populate structured data in our family history web form and would be stored in the data repository. Or it says I can actually perform a risk assessment. I can do a second level of assessment to do this. So I click that button and I get this big message, increased risk for coronary artery disease, and it tells me why. There are 2 first-degree relatives that have had premature CAD. Now, I could add this to the problem list, and if I click that button, then the problem list, which many physicians use to manage their patients over time, it would say family history of early onset coronary artery disease. But it also says I can assess cardiovascular risk using clinical data. If I click that button, it shows me that based on the information we currently have, Grant has a moderate cardiovascular risk because there are more than 2 risk factors. And what this has done, that button click, has populated information that already resides in the electronic health record, including blood pressure information, cholesterol levels, information that Grant has filled in relating to smoking history, this sort of thing. And it's highlighted those things that are present. And it also tells me that we used an accepted evidence-based risk stratification called ATP3 to develop this. But it also tells me you should consider inflammatory marker testing to reclassify the risk. And that's an info button. And if I click on that, what that shows me is that if we do an inflammatory marker test, of which one or the other of these would be possible, if that is not elevated, then it gives me an LDL target of less than 130. But if it is elevated, then it would say we need to treat to a more aggressive LDL target because this person has been moved into a cardiovascular risk equivalent. And it also gives me links to references that say, here's the evidence base for which we have run this particular algorithm. Now, I can schedule this Grant for an appointment, but I see that I've seen him relatively recently. But it also says that I can order a test and notify the patient. And if I click that button, we're now back in the patient portal. And here's a message. Grant has a message. It's from me. And when he opens it up, it says, we have reviewed your updated family history. We've identified increased risk for cardiovascular disease. This information, when combined with your personal risk factors, places you in the moderate risk category for cardiovascular disease. There's a blood test that can help us determine treatment goals that can reduce your chances of having a problem. An order has been placed in the system. You can contact the scheduling clerk to make arrangements to have the test performed. I will contact you with the results. So here we've done a very sophisticated transaction based on evidence, best evidence, that would allow something to be done in a very efficient way without disrupting Grant's life by having to come into the doctor's office and hope that I took a family history and hope that I remembered that maybe we should do something relating to cardiovascular disease. It can all happen very effectively. Now, I mentioned that we were going to use this as a gap analysis because as nice as this looks, we haven't gotten to the point where we've actually gotten this up and running yet. We have parts of it, and we have the concept, but there are barriers in the way for us to actually do this. And I wanted to make one other mention related to patient-centeredness. I think it's really important. One thing we added to the family history tool was the opportunity for a patient to enter a message that says, I have done my family history, and I am most concerned about this. So our risk algorithm shows us cardiovascular disease risk, but maybe the patient's father just was diagnosed with colorectal cancer, and they really want to talk about colorectal cancer. I think that's a way that we can pre-negotiate patient visits to be able to enable shared decision-making, because some of the recommendations about lifestyle modifications that would reduce colorectal cancer risk also happen to reduce cardiovascular risk. But if we contextualize it, then perhaps we can develop a more effective plan that we can both agree to going forward. So the organizing questions we were asked to address was, what does the current landscape of family history and genomics and health IT look like from your point of view? Over the next 2 years, what are the 3 outcomes related to health IT that are highest priority to ensure patients can benefit? And what actions need to be taken and in what order to meet these priorities? This is the current landscape, which those of you who have visited southern Utah are probably familiar with. It's pretty barren. We do have family history and meaningful use, but it's at a point where it's really highly unhelpful, at least to do the functionality that was just described. We now have, it was mentioned, I think, by one of the people in an earlier panel about that we have evidence is saying, well, there's really no utility to family history, and there was an NIH State of the Science conference that basically said, well, we don't see any good evidence. Well, there were 2 problems with that. One is they didn't look far enough back in the medical literature to identify some very good studies that are actually done here by Ted Adams, who I don't think is here any longer, that were excellent. But also, more recently, there's an article by Nadim Qureshi that shows that use of family history can dramatically improve cardiovascular outcomes. One of the first prospective trials, which led the former head of the United States Preventive Services Task Force, who had led the NIH State of the Science Conference and was very critical to say, I was wrong. This shows that this really does have utility. So I thought that was good. We don't have standards in interoperability. We've heard about that. There are emerging projects, some of which we've already heard about. And then there's the ongoing work here at Intermountain being led by Pallavi Ranade, who's not here because her daughter is a semifinalist in the Scripps Spelling Bee and is doing that today. So we do have storage of the family history in the clinical data repository. We have unique identifiers for family members. We can integrate the family history with a problem list. We can develop the family health history model, storage strategy for associated data, in other words, the other data that needs to be attached to family history, and the terminology issues which are ongoing. 3 outcomes to prioritize. What is your favorite color? No. Develop patient-entered family history tools that are standards-based, use a single data storage model, can seamlessly share data between tools, can interact without the loss of data or functionality with any fully functional EHR. Create computable family history clinical decision support artifacts based on appropriate levels of evidence and clinical best practices that are generalizable and implementable across all fully functional electronic health record platforms. And develop a suite of family history apps that can be trialed within EHR environments to rapidly identify innovative approaches to collect and use family history information. What actions should we take? I think we need to create a research agenda and funding to expand the capacity to test family history tools and impact on patient care. That does not necessarily mean that it has to be government funded or NIH funded. I think basically all players are welcome in this arena. We need to continue and accelerate efforts to take family history data model through the national, international HIT certification process, something we've already talked about. Many of us have been working on for years. Explore sharing of family history with relatives to enhance collection of complete information and lower barriers for family members who don't have the access or ability to create their own. Test the ability to create family history from existing clinical data using genealogic family construction approaches as piloted by the Utah Population Database and Intermountain. In other words, if I can take publicly available data and create your family and link that to electronic health record data, why do I even need to ask you about your family history? I can just do it. and I can run the decision support. And it actually can be done. We haven't told HIPAA about it, but we can do it. We need to develop a policy agenda to identify and propose solutions to barriers imposed by the current privacy rules, including HIPAA and GINA. Thank you.